however it comes out.
I forgot to ask you, Dr. Sura, are you able to see the chat and the Q&A at the bottom?
No.
Let's see.
Wait, I can press a button that says Q&A.
Do you see the chat down there too?
Yeah, yes. I can also see the chat.
Okay.
Yes.
Cool.
Oops. Did not mean to do that. There we go.
Can they hear us?
Yes, they can. All right, good. Thank you, Virginia, for putting something in the chat. Thank you so much. Actually, if you want to put in the chat where you're from, let us know where you're from. So I would like to thank everybody for attending the NAFTA 2022, actually the last 2022 webinar of the year. Again, thank you for joining us tonight. Our topic tonight is focus on anesthetic safety, diagnostics for patients with comorbidities. Got that one right. Our speaker tonight is Dr. Tamara. Now here I go. I can't. Tamara Grubb, and we also have our sponsor tonight is Zoetis, and we have Dr. Shannon Sura from Zoetis with us. So thank you, ladies. Just some housekeeping rules. Everybody is muted. If you have a question, and please, 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 if it's a question that you really want answered, make sure you put it in the Q&A. That way we won't lose it, because the chat is a live, live feed, so a question could get answered, but most certainly use the chat to talk amongst yourself and everything. But if it's truly a question you want answered, go ahead and put it in the Q&A and we will get that answered. Dr. Sura is going to watch for the questions. If it's something that's pertains to what Dr. Grubb's talking about, she will interrupt and we'll go ahead and get that question answered. So we're due for an hour tonight. So right now I would like to turn it over to Dr. Sura.
Hey everybody, I'd like to introduce, gosh, I hope I say this right now, Dr. Tamara Grubb is a diplomat of the American College of Veterinary Anesthesia and Anesthesiology with a strong focus in pain management. She owns an anesthesia, analgesia, continuing education consulting practice, which serves both small and large animals, DACVAA. Dr. Grubb is a national and international educator and lecturer, a certified acupuncturist, an adjunct professor of anesthesia and anesthesiology and analgesia at Washington State, and is president-elect of the International Veterinary Academy of Pain Management. She is co-author of 2 books, including Veterinary Anesthesia and Pain Management for Nurses and Technicians. Dr. Grubb's favorite achievement is winning the Distinguished Teaching Award at 2 universities. I'm going to go ahead and pass it over to Dr. Grubb.
Excellent. Thank you. I really appreciate the introduction, Dr. Sura, and your time. And Lori, thanks for getting us all organized. Y'all, this is one of my very favorite topics, anesthetic safety, because we all know nothing could be as important as anesthetic safety. Okay, pain management, but that's part of anesthetic safety. And in case you can hear my dog in the background, she's completely agreeing with me, but she will lay down here in just a second. The way to really ensure anesthetic safety is to make sure that we do good diagnostics, and especially in our patients with comorbidities, right? Those are the scary ones. And I want to thank Zoetis for sponsoring this. Zoetis has always been so supportive of anesthesia and pain management. And without Zoetis, we wouldn't be here together in this session. So thank you. And thanks to you guys, the audience. You're the one doing anesthesia. You're the one that knows what we're going to talk about. It's probably a review for many of you. And if it is good for you, you're doing great anesthesia. But I hope to have some tips for everyone out there. But thanks for all you guys do at NAVTA for us as doctors who couldn't do our jobs without you, and most especially for our patients. And I realize I'm biased, but most especially in the area of anesthesia and pain management. All right, so onward. I have a disclosure. It's not a conflict of interest. It is just a disclosure of who I consult with. And guys, I'll consult with anybody that has an anesthesia, analgesia product or drug, or even an idea. because I want to know everything that's out there. But I want to know it not just selfishly, but also to bring it to you so that you get the cutting edge information. And Zoetis is sponsoring this, and we will have some images and some information from Zoetis, and also some images from Midmark and some of the other companies. So this is a balanced presentation. It's about the patient, right? It's really not about any products. It's about the patient. So here's my first poll. And Lori, if you'll put the poll up, please. I know that everyone knows the answer to this question, and it's complete review, but I want to see where you guys are at. So quickly answer it. You're going to know it right off the bat. So this is one of the most important roles of the anesthetist: stabilize the patient, provide analgesia, support oxygen delivery, or all of these are important. And I can see the answers flying in. You guys are amazing already, I can tell. All right, so Lori, they can see that? Excellent. So you guys obviously are right. I knew you would pick that, but the real reason I put it out there we go. I knew you would pick all of these are important. And I really put it out there to set the stage of what all we are going to talk about. And it is those four things, it includes those four things. So if we can, let me see if I can take that off them. So I think everybody saw that. All of these are important. And now I'm going to take that off of there. All right, onward we go. Whoops, on. Ready? Onward we go. I'm really better at anesthesia than PowerPoint sometimes. So here we go. Now we're going onward. I think most people, and I bet you guys would agree with me, they think when I say anesthesia, what do you do for anesthesia? They think of the maintenance phase of anesthesia when that patient is actually unconscious. And I understand that. Again, the patient is unconscious and they spend the most time in maintenance generally. But remember, there are four equally important phases of anesthesia. We start with pre-anesthesia, and then induction, then maintenance, and then also recovery, right? Recovery is equally important. All four phases are equally important. And what you see on the screen there is just a little miniature checklist. Obviously not the robust checklist we should be using on the day of anesthesia, but just a little 30,000 foot level checklist of what would happen in each one of those phases. And I'm going to say that I think pre-anesthesia and this part, the stabilization of the patient, preparing that patient for anesthesia, I think that's the most important step that we take. Because if we have that patient safely prepared for anesthesia, meaning having it as stable as we can, that impacts all the other phases of anesthesia, and it positively impacts the phases if we have them, again, stabilized, and negatively if we don't. So what do we need to do then to prepare that patient for anesthesia? And we want to start with our diagnostics. And every patient, again, a review, should have a thorough medical history and a full physical exam. Our patients should also, before they're anesthetized, have any biochemistry diagnostics that they need. So blood or serum chemistry, urine analysis, and also any other type of diagnostics that they need. Often we need an ECG before anesthesia, or a blood pressure, or we might need some imaging, right? Whatever diagnostics are appropriate for that comorbidity. Because then we're going to use those diagnostics to stabilize the patient. And stabilization is very dependent on the patient itself and on the disease. So as you can see examples on the slide, it might be acute stabilization. So a patient comes in that's been vomiting, and so we need some IV fluids, maybe some electrolytes for a couple of hours before anesthesia. Or it might be chronic stabilization, like a patient with heart disease that we send home on some drug, maybe pemobendin, for days to weeks, sometimes even months, depending on how bad the comorbidity is, and also how urgent the anesthesia is, right? What are we anesthetizing the patient for? But this pre-anesthesia stabilization really improves anesthetic safety. Again, review. But I want to show you how much it improves anesthetic safety. And we're going to start with a chart that's probably going to make you shudder, like, because we tortured you with this, right? The American Society of Anesthesiologists risk factor chart. And so everybody's probably going, oh, not that again. But just remember really quickly, an ASA 1 patient is a patient that is healthy, that has no inherent disease that would increase the risk for adverse events under anesthesia. And of course, there's always a small risk because anesthesia causes central nervous system depression, cardiovascular system depression, respiratory system depression, right? We're going to fix that, of course, as we go along here in this discussion. But there's that small risk then is compounded as that patient gets sicker. So ASA 2, mild disease, 3, moderate disease, 4, severe disease, and then 5 are the patients we don't want to anesthetize. We only anesthetize them if they have to be anesthetized for a life-saving procedure. So let's look at the impact of the ASA status on the ultimate anesthetic complication, and that's anesthetic death. Nobody wants to talk about anesthetic death. And we would really rather know morbidity versus mortality, right? Because with morbidity, we still have a chance to fix it. But morbidity is a little bit more difficult to study because which really is a bad end-tidal CO2? Is it 50 or 55, 47, right? It's a bit nebulous for the things that we monitor. There's not an exact number, whereas death is pretty exact. Plus, by knowing what makes patients die, right, we can catch that before they're dead. So we're still studying morbidity, just endpoint. And what we're going to look at is the impact of the ASA status, the underlying morbidity that they already have, on the risk for anesthetic death. And you can see that ASA 1 and 2 patients have a very low risk of anesthetic death. 3 to 5, it increases by more than a decimal point. And in fact, we know that just making small jumps, increasing from an ASA 1 or 2 to a 3, or from a 3 to a 4 to a 5, that increases the risk of death by 3 to 6 times. That's a lot, isn't it? That's a lot. As an anesthetist, I'll do anything I can to decrease that. And that's the important part of this discussion, because probably some of you are thinking like, duh, the sicker they are, the more likely they are to die. We already had that. But it's just remembering to turn it around and stabilizing those patients and decreasing that ASA status. We can't take a 5 to a 1 or even a 4 to a 1. But if we could take a 4 to a 3 or a 3 to a 2 with fluids, oxygen, pemibendin, whatever it takes, that actually makes a huge difference, right, in the safety of our patients under anesthesia. And if it keeps us from having to make that phone call that says your pet died under anesthesia, I'd do anything to not have to make that phone call. All right, let's move on into pain. Here we have the next poll, Lori, if you don't mind. And I want you guys to think about pain. Can pain exacerbate or make worse the negative effects of diseases? Do you think that statement, pain can exacerbate, is that true or false? So Lori, do you have, oh, there we go, perfect, sorry. Patience is a virtue, it just isn't my virtue, you guys. I'm not very good at that. All right, I see things rolling in, excellent. I have the best audience. I love this. It's, again, you guys are doing the anesthesia. You know all of this. You know the answers. Awesome. All right. Excellent. So good. Look at that. Almost everybody said true. And I'll bet the one person that said false meant to put true. Because of course, pain can make diseases worse. And let's just look at that a little bit deeper. Oh, here we go with the PowerPoint. There we go. True. Pain can exacerbate or worsen the negative effects of many diseases. So let's look at the nervous system. What you're seeing here, walk through it with me. In the upper right-hand corner is the brain. So we see the hypothalamus, right? And if the patient is stressed, so just from stress in general, or from illness, or from pain, pain is a tremendous stressor. We see that from the brain through the spinal cord down to the adrenals, we get this stimulus and the release of catecholamines. And of course, catecholamines are excitatory neurotransmitters. So then those catecholamines are in the blood, they go out to all the other organs. And you can see here just some of the negative impacts of catecholamines: increased heart rate, for instance, and then over on the right, increased blood pressure. So if the patient already has cardiac disease, right, pain can make that worse. We don't need to increase the rate or the blood pressure in a patient with cardiac disease. Or we see in the middle there, increased glucose, that can negatively impact a diabetic. And then you see changes in GI motility. So if they have a GI disease, then obviously pain can impact that. So yes, pain can make the patient worse. So we'll talk a lot about pain management in our protocols. The other thing to talk about, of course, is what is all so important and what you're so good at. And that is physiologic monitoring and support, because really we could use the wrong drug in the wrong patient. I don't know what the wrong drug and wrong patient is, but just pretend like we pick something. It's like, oh, I wish I hadn't done that. But as long as we are monitoring that patient and supporting any physiologic abnormalities, right, that patient will probably do just fine. And one of our big jobs as anesthetists is to support oxygen delivery, because of course every cell needs oxygen as its fuel. It can't survive without oxygen, and unfortunately, many of the anesthetic drugs, or most, cause some decrease in both cardiovascular and respiratory function, and those are both critical to oxygen delivery. Patient has to be breathing to get the oxygen, and the heart has to be working to get to the lungs to pick up the oxygen to take it back out to the cells. So that is our job. It's also our job to support body temperature to the best of our ability. I don't have any huge tips or secrets, but just think about it. Just think about the enzymatic processes that run all of the organs that make them work. Those enzymatic processes, sorry, I'm looking at my clock to make sure I don't run over. Those enzymatic processes function under a fairly narrow pH range, and also a fairly narrow, not quite as narrow, but fairly narrow temperature range. So when the patient is too cold or too hot, right, those physiologic processes start to fail. And we can see repercussions with hypothermia, like decreased cardiac contractility. If you can hear that, there go my dogs supporting the thought of physiologic monitoring and support. Apologies. So excuse me, hey. So I think someone's breaking in, or they really agree with physiologic monitoring. So with hypothermia, we see decreased cardiac contractility, we see delayed recovery, we see delayed metabolism of drugs. So hypothermia really is a pathology. So we need to do our best to keep our patients warm. So here's our first patient. We'll get the dogs quieted down just a second. Here's our first patient. This is Poppy. And Poppy really is a female orange cat, right? The all elusive female orange cat. And she has presented from the owner with a really hard knot on her abdomen. And we're presuming that it's a mammary tumor just based on its description. We haven't done a biopsy. To our knowledge, this cat is perfectly healthy. She's had no health concerns. We saw her last year for her vaccines. Everything looked good. So we're pretty sure she's ready for anesthesia. She's a little bit underweight and she's got this mass. She does have hypertension, but I didn't know that at presentation, right? I'm just putting it now so that I don't forget to tell you guys, but we didn't know hypertension at this moment. We don't do blood pressure as a routine part of exam in all of our patients. And so we didn't know yet. So it's time to do some other diagnostics, and we did thoracic radiographs and there was no indication of metastasis. So let's go do some biochemistry diagnostics, right? Let's do our serum chemistry, our complete blood cell count, and a urine analysis in this kitty. Surprise. I have the title as surprise because we thought she was perfectly healthy, right? No complaints. At that moment, we didn't know she was hypertensive. We took her blood pressure after we saw this blood work. But now you can see this very high BUN and creatinine. And you can also see she's got some protein in her urine. And you could use this picture is just to remind you, you could use an iStat to get some of these results too. So you can use various diagnostic tools. That's why they're all on there. So surprise, but it shouldn't be, because how many times do we do our diagnostic test and find something that makes that patient an ASA 2 or a 3 or something other than an ASA 1? So let me just show you the results from a couple of studies here just to make the point. This first study is healthy dogs, averaged a little over 10 years old, and the second one, healthy cats. I mean, to our knowledge, healthy, averaged almost 12 years old. So we're looking at a senior population. They all had serum, CBC and serum chemistry or blood work just before anesthesia. And look at this, 21% of the dogs did not proceed to general anesthesia for a variety of reasons, including what we found on these diagnostics. And 4% had actually changed anesthetic protocols. Now, that doesn't sound like a very big number, but I'm going to come back to that. We all know that we don't often change the drugs, right? We might change the management. That happens a lot. So I'll come back to that. But look, 20% didn't go to general anesthesia, and they were thought to be healthy. Same way with these cats. Again, 21%, which I find a bit odd because cats have to be different, but they were different by 0.01%. 21.5 versus 21.51, didn't proceed to general anesthesia for a variety of reasons, including abnormal blood test results. And then down here, when we get to the older dogs, the true geriatrics, 30% of them had a new diagnosis that nobody even knew, that identified on their pre-anesthesia screening, right? Not brought in because they weren't feeling well. They were there for anesthesia. And you can see about 13% didn't go to general anesthesia. So here's the next poll. So Lori, if you will launch this poll, please. We were just looking at patients that were aged, right? Seniors or geriatrics. So what do you guys think? True or false? Pre-anesthetic diagnostics are only important in geriatric patients. You guys are rocking it in here again. Sorry, I keep looking at the clock. I don't want to be late. All right, you guys rocked it. That is so awesome. False. Thank you for that. Absolutely false. And even though we know that our patients are more likely to have comorbidities as they age, right? And comorbidities are not just part of the geriatric population. So false. And let's reinforce that with a study here in younger patients. These are dogs, 6 years old. I'm sure the same would be true of cats. I just don't have a cat study to share with you, but let's say cats will be the same. Don't tell cats, but they would be the same. And look at this, 8% were sicker than we thought they were, right? They were hiding their disease. And if we don't classify them properly, if we don't get the high ASA status, sometimes we don't pay as much attention, we don't stabilize them as well, we don't support them as well. We know that from human medicine, that if the higher the ASA status, the more attentive the nurse is, right? So we want to make sure that we get the correct ASA status. And so you can see here that based on 0.8% had their procedure postponed, and then the protocol altered in 2 patients, 0.2%. So definitely it's a much smaller number than we were looking at in senior patients, because again, we're more likely to have disease as we age, and our patients are more likely to have disease as they age. But this isn't a herd medicine, right? We're not talking about a herd of cattle. We are talking about individual pets. That could be your great Aunt Sally's dog right there, or your receptionist cat, or really anybody's dog or cat, right? They all matter. So even if it's a small percentage, we want to make sure that we identify those problems before we do anesthesia and stabilize the patient and decrease the anesthetic risk. And also, as a veterinarian, and I'm sure you guys are the same as veterinary technicians, I want to know the underlying health status just because I want to know, right? It doesn't have to be just because they're being anesthetized. I want to know how healthy my patients are. And if we look at these 2 patients, the one on the left is a breed that very likely could have some cardiac disease. So this little puppy saying, hey, do I have a heart murmur? And the answer is like, I don't know, because it's my first time to the vet. I haven't had an exam. We would not anesthetize this puppy without putting a stethoscope on it. And how about this species that is highly likely to have something underlying like chronic kidney disease? Hey, do I have renal compromise? And nobody knows, my first trip to the vet, right? So we want to make sure we do our serum chemistry and other diagnostics as well. All right, so let's now look at the changes in protocol that I mentioned. And I said, and you guys know this, we very rarely change the protocol based on our serum chemistry, our biochemistry results. We often change the drugs based on the physical exam, right? We might choose a different drug we might choose an alpha-2 agonist or ace-promazine or something based on cardiac. But when we get our serum chemistry, honestly, we don't change the drugs very often. We might change if we have chosen a drug that is hepatically metabolized or renally excreted, and maybe they have hepatic dysfunction that we just discovered. We might change it. Or some of the other things that like specific disease effects might cause us to change the drugs. But quite frankly, the drugs don't change as often as the plan changes, right? The management can change a lot. So it can dictate the exact fluids we choose, the additives to the fluids, the duration of fluids, how early we start, how long we go. Also specific treatments like glucose and the need for continued monitoring. If we see something that's like, ooh, that could change under anesthesia, we now know because of these preoperative diagnostics that we want to watch that. And also, and I know as nurses, like technicians, this is the most important thing, it allows us to be prepared. So we know, let's just pick potassium, pretend that potassium wasn't quite normal, it could change under anesthesia. We want to be prepared with a plan. If that patient gets hyperkalemia, this is what we'll do, right? So now we're ready. So the management changes more than the drugs. All right, let's go back to this. And now we have our patient prepared. So back to Poppy, our kitty. So we sent her home for long-term stabilization. Her diagnosis, chronic kidney disease, IRIS stage 2, the International Renal Interest Society. And how did we choose how to stabilize her based on those IRIS guidelines, right? That's what we used to stabilize her. She also has this mass. So we're going to use the IRIS staging. We don't want to anesthetize her until she's stable, because remember that stress response from surgery, from pain, that can actually make renal function worse. And we want to make sure we don't wait too long. We want to get this mass off. But the good thing for Poppy is that this is not an emergency, right? So we have a little bit of time to get her ready. So this is what we did. We sent her home with prescription renal diet and monitoring water intake. Something to decrease that blood pressure. We chose amlodipine. In your practice, it might be something different, whatever decreases that blood pressure. And how do I know the drugs are working? I like to check that blood pressure in just a few days to make sure there's really a difference. And some owners can measure it at home with something like a pet map or something. Not everybody can, but sometimes. And then we'll recheck that kidney panel in probably 3 to 4 weeks again, because we're not in a rush with this cat, or certainly more quickly if there's any change in the physical status of the cat. So we did all of that the day of anesthesia. Look at this, yay. We're not trying to cure chronic kidney disease, right? We don't have a cure for that, but what we want is a stable patient. So now we see a stable patient, the BUNs come down, the creatinine's about the same, but no worse. The systolic arterial pressure is now 130, so perfectly normal, and no protein in the urine. So we're ready to go for anesthesia. Now I want to share my plan with you. It'd be the same as your plan. The anesthesia concerns are in yellow and the goals to fix it are in green. And of course, we want to make sure that we keep the inhalant dosages low and support blood pressure and support ventilation to counteract the cardiovascular and respiratory negative impact that can occur with many of our drugs, especially the inhalants. Also, we've already talked about pain. It can cause vasoconstriction from the catecholamine release from the stress response. That can further decrease renal blood flow and further add to kidney damage. We know that the kidneys aren't quite working properly, right? So we've already talked about minimizing drugs that might require renal clearance as their only route of elimination. And then also we know that these patients are often thin, and of course they get hypothermic very quickly. And we've already talked about the negative impact of hypothermia. And also we want to make sure we pad them carefully so they don't get any pressure sores. So it's not just about the drugs, right? So here, oops, keep warm and pet. Okay, so here she is, the day of anesthesia. She's coming into the clinic. You may or may not discontinue the amlodipine. That's a whole nother discussion. But what we do want to add is gabapentin, because I forgot to point out on her physical exam, she was very nervous. And that those high anxiety patients, as we all know, can be more difficult to sedate and anesthetize, because anytime the patient has high anxiety or fear or stress, takes a higher dose of sedatives and induction drugs and often maintenance drugs to keep them asleep. And that actually puts the pet at increased risk for adverse events, because the adverse effects of these drugs are primarily dose dependent. So when we have to increase the dose, then that increases the risk. So by keeping that patient calm, that definitely does help have a safer anesthesia. Now I put there just as a fact, remember gabapentin is the clearance is slowed in patients with renal disease But this really is not an issue for this acute administration. We would have a dose reduction if we put this cat on chronic gabapentin for chronic pain, right? But not just for today. In the
Dr.
hospital,
Grubb?
we're going to start her on some IV fluids for about, yeah.
You have a question here. We all would like to do diagnostics the day of. However, many clinics allow BW with one month of GA for elective, 6 for dental prophy, mask removal. What is your window in which you require diagnostics?
Ooh, great question. And thank you for stopping me and letting me answer it right now, because it's an important one to answer now. You know, I'm the same as what was just described. If the patients are healthy to start with, right? So a month, again, young, healthy, 6 months, if that I don't think that's unreasonable at all, especially if they're coming in for something that's not like a GI foreign body and they've been vomiting and we need to see some electrolytes, right? So yeah, 30 days, 3 months, maybe 6 is okay in those young, healthy ones. So the difference in these guys is we're talking about patients that are already sick. So they're already ASA 3, right, at least. And so that's when we do them the day of, not in every patient though. Our practice is just like yours. Thank you. That was a great question and a very good clarification point. All right, so we're going to stabilize her based on the IRIS, the IRIS guidelines. And remember that there's sometimes vomiting. So we want to make sure we treat any vomiting, because that can also add to dehydration and electrolyte imbalances. All right, next poll, if you wouldn't mind, Lori. We're about to talk about drugs. What drugs are contraindicated in patients with underlying disease? Like any underlying disease, you pick. Heart, respiratory, what's contraindicated? What can we really not use? You guys are rocking it again. I need to rock it. Good. You guys are fast too at answering. I'm gonna check one more time, make sure my watch is really right. I don't want to keep you all like for 2 hours. I would love to, but you probably have stuff to do. All right, good. You guys did great. All right, excellent. And almost everybody picked the answer that I would pick, and that is that. Let me put this on my slide. That there's very few true contraindications, like you cannot use this drug, but always considerations like which drug would I rather have. And good for you guys though for just thinking about the others. And the next most common answer was inhalants, and that's definitely the drug class we want to keep the lowest. Sedatives, sometimes they're so sick they don't need a sedative, so I get that selection. But honestly, we don't want to just rely on our induction and our inhalants for the whole anesthesia, right? We want some sedatives if they need them. And then propofol, okay, it can cause hypotension, so maybe not appropriate for every patient. But the big one is definitely most are not truly contraindicated. And I know a lot of them say that on the label, that they're contraindicated, but oftentimes it's just because they have not been studied in that specific disease. And so we want to make sure we use them safely and think about, they're really contraindicated or just do we want to have some considerations? So let's look at our sedatives just in general. Opioids, absolutely. Analgesia, they're reversible if you wanted to. We need to prevent vomiting. They cause minimal cardiovascular and respiratory changes, and so they help us support that oxygen delivery. The benzodiazepines, always an option. They're incredibly safe, right? But they're not very sedating. So for me, they're more often a part of induction than pre-med. Alfaxalone, excellent option for especially cats and very small patients. We can give it IM. Acepromazine, in this particular patient, I like acepromazine a lot in healthy patients. In this particular patient, it's not my favorite. So I have a yellow caution X, not a red, like don't use it, but just a caution, because this patient, I really do not want hypotension. We've got to perfuse those kidneys, right? And that vasodilation from ACE could contribute to some hypotension. So not my favorite, but not contraindicated. And then alpha-2 agonist, again, an option, provides some analgesia and they're reversible. How about induction? Propofol and alfaxalone are both options in this patient. I think they'd be very good choices. Ketamine and taletamine zolazepam are also good choices. The only difference with them is they're a little bit harder to titrate to effect. because they're slower onset. Whereas propofol and alfaxalone, remember, both of them cause some respiratory and cardiovascular depression, but they work really fast. So they're easy to titrate to effect. So we can give each patient its exact dose, right? And not overdose the patient. The other thing with ketamine and taletamine, so I have another yellow box, is they are both cleared in part by the kidney. Honestly, it's not going to be an issue in this cat. If that's the drug, if those are the drugs I had, I would completely anesthetize this cat with one of them. But since I have propofol and alfaxalone that don't require that renal clearance, I would pick those instead in this cat. Now we're going to talk about ketamine and the constant rate infusion for pain. That dose is so low, it is so low that it is not a concern even with renal insufficiency, not worried at all. Etomidate, remember, that's the drug we choose if patients have severe cardiovascular disease, so it's an option. Most of us don't have it in practice. I'm sure some folks out there are in academia, and we do have it in academia because we also have cardiologists, right? So we get a lot of patients with very bad hearts. This is the one we're not going to use, right? We're not going to box this cat down. This is not the way to anesthetize patients. It's too slow. They go through a major stress response, and we've seen what stress can do, whether it's from pain or from boxing them down. Also, the dose has to be really high. So by the time they're actually asleep, because it takes time and the dose is high, the blood pressure is usually really bad. Plus, somebody has to get the cat out of the box and breathe in that gas. And it's not good for humans to have that chronic exposure and can cause health effects like migraines, immunosuppression, right? There's known health effects. Okay, so now we're to the maintenance phase for this kitty. We induced it, we're to the maintenance phase. Absolutely, we want to provide some local blocks around that mass. The local anesthetics, actually, I've got the circles showing that the one in the brain, the local anesthetics not only provide analgesia, the big X was the local anesthetics block pain at transmission, so that painful impulse doesn't get to the central nervous system. That in the brain provides anesthetic safety, right? Because we all know it's a lot easier to keep the patient asleep if it's not responding to pain. Yeah.
I've got a question about the use of etomidate. One of the attendees wrote in that they were taught to split it, to dilute it 50-50 because it can be hard on the kidneys when administered.
Yeah, it's a good point and a good way to do it. The thing with our pre-meds, the dose is low enough that I'm not worried about the renal function. But I agree with your comment that if it is a patient that is going to require a higher dose of etomidate, doing something to be able to decrease that dose, like maybe splitting the 50-50 would be a good choice. So yeah, thank you for that. That's awesome. So the local anesthetics improve anesthetic safety because it's much easier to keep a patient asleep if they're not getting painful signals to their brain, right? So we can keep that inhalant dose lower. And then also the local anesthetics, because they're blocking pain to the spinal cord, that's where central sensitization occurs or wind up. So it makes it less likely that wind up or amplification of that pain signal occurs, right? So that has a big impact in recovery because their pain stays lower for longer if they had a block than if they did not have a block, because the pain is just a normal level and not that amplified pain.
Dr. Grubb?
Yeah.
There's another question. Do you worry about potentially seeding the mass tumor with the local block?
Yeah, very good question. Technique is critical, isn't it? So here we have our tumor, and we want to inject that local anesthetic way out to the outside where the surgeon's going to be doing their incision, right? Because they also don't want to see that tumor by the scalpel blade. So they're going to make a really wide margin, and that's where we want our local blocks to be. And even better, that's not a choice in this kitty, but it's even better if you can block a peripheral nerve that's far from that tumor site. So let's just say a kitty had a tumor on its paw, then we could do like a brachial plexus block or a RUM block to block far away from that tumor. So absolutely right. Get that needle as far away from the tumor as possible. And if you really can't find a way to block it without getting close to the tumor, then no, we wouldn't put the needle in. Really good point. Technique, everything. Thanks, you guys. Cool. And then don't forget to support our tissue oxygen delivery. The kidneys really need that. They're already compromised. We want to keep that blood pressure at greater than 60 millimeters of mercury. Some people say greater than 70 in patients with chronic kidney disease because they're already hypertensive. There's no evidence one way or the other, but 70 is a good goal as well. No harm in keeping it a little bit higher. And then, of course, end-tidal CO2 less than 55. 45 is normal when we're awake, and that's a good anesthetic goal. But we all know that sometimes it creeps up a little bit, but we don't want it more than 55. Because then we start to get respiratory acidosis. So 45 is awesome, up to 55 is tolerable, higher than that, no. All right, I think this is our last poll. What is the riskiest phase of anesthesia? So especially these patients with underlying disease, they're already at risk for anesthetic death. So Lori, if you would launch this last poll, let's see what everybody has to say. What is the riskiest phase of anesthesia? When do you think the most adverse effects occur? Awesome, good. Good, you guys are doing great. All right, let's see what you say. Yep, recovery. Most unexpected deaths occur in recovery. Now, adverse events can occur at any phase. So I'm glad you guys we're thinking and choosing among all of them. But most unexpected deaths occur in recovery. And generally it's in these patients with comorbidities or patients that just didn't do great under anesthesia. And so there's something underlying that's not right. So they need more support. They need continued monitoring and support in recovery. All right, so here is what we did for Poppy for recovery, just continued that monitoring and support, continued the IV fluids for a couple of hours based on the IRIS guidelines, keeping that stress low, and that includes treating pain or excitement and keeping them warm. If you've ever been hypothermic, it is not very comfortable, right? It absolutely does not feel very good. And then discharge with analgesic drugs and continues to support for the renal disease. We didn't cure that. We just managed to safely anesthetize the patient. And so here we have at the recheck, you can see again, we have stable disease. We didn't destabilize it with our anesthetic drugs. And you can see my choice is gabapentin, hydromorphone. It could have been any opioid with some midazolam. I had to give more midazolam at induction because Poppy's an orange kitty. I should have chosen maybe dexmedetomidine, and then midazolam and propofol for induction. It could have been alfaxalone, right? It could have been alfaxalone in the pre-meds, right? All of those we talked about are good options. This just happened to be my choices, but we all of those were good. And then isoflurane. We did a bupivacaine block, we did a bupivacaine block, and then we did some liposomal bupivacaine at closure. Remember, that's a 72-hour duration local anesthetic. And we did that because we're not sending this cat home with NSAIDs, right? So we need to make up for not having NSAIDs available because this is a chronic kidney disease cat. Now, for chronic pain, if they have stable chronic kidney disease, I definitely use NSAIDs. But anesthesia creates an potentially unstable situation, right? So I would wait several weeks after anesthesia to start the cat on NSAIDs if it needed it for chronic pain. But that's why we did the longer duration block. Okay, guys, let's squeeze in one more patient. Keep the questions coming. Here is Harley. He's super anxious. I mean, go figure. If your owner dresses you in a devil costume, you're probably super anxious. He's not eating, and if you touch his head, he bites. He really doesn't want to be touched at all. Starting to pee in the house. No other complaints, the owner said. So we looked at his teeth, really terrible teeth, high-stage periodontal disease. So is he not eating just because of his dental disease? Yeah.
I have a question here asking if you've used Zorbium yet, what your thoughts are.
Yes, absolutely. Zorbium. I like both of the long duration buprenorphine products. So Cimbidol lasts 24 hours and Zorbium lasts 4 days. And I like both of those because we want the longer duration products, especially in cats so both of those are for cats, right? Not for dogs. Especially cats like with dental disease where we don't want to be giving them oral medication, and cats are just hard to medicate anyway. So anytime we can use those longer duration drugs, yes, I fully endorse those products. Please use them. They're awesome. Okay, thanks you guys. So Harley, is he not eating because of the dental disease and he doesn't want to be touched because he's painful? We better go see. And guess what? That's not his only problem, right? He also has really high glucose, serum glucose, and he's got glucose in the urine. And guess what? Just to top that all off, he's got white blood cells and bacteria in the urine, right? Couldn't be easy. So what do we have here? We have type 2 diabetes, we've got cystitis, we've got periodontal disease. We need to stabilize him. We do not want to take a diabetic, unstable diabetic to anesthesia. Those are more unstable than we realize, I think, right? There's a lot going on, and we can cause DKA, diabetic ketoacidosis, if they're not stabilized. But we also know that periodontal disease can make diabetes worse, right? It can impact our ability to stabilize that glucose, in part because the patient doesn't want to eat. Yeah.
Can I interrupt you again?
That's quite all right.
Follow-up questions just around Zorbium, and if you've seen, I'm gonna shorten the question, but if you've seen any like euphoria or excitability in response to the use of these drugs.
Do you know, another great question. Thank you, guys. I have not. And it's amazing, the safety studies of the Zorbium and the Simidol, really those cats, it was kind of a surprise to start seeing a little bit of that or hearing about it in cats out, like real cats in our practices, not just the research cats. And I think a couple of things might be happening, and I'm going to touch wood. I haven't seen it yet, but I love the part of the question that said euphoria, because I really think some of those cats go home and the owner thinks that they're dysphoric because they're different, right? But we all know cats on opioids. What do cats on opioids do? Sometimes they're dysphoric, but a lot of times it's euphoria. They're like, happy, I've got my opioid. So yes, it can happen. And yes, I know there are some reports of that. And I think one of the things we need to do is two things. One is look at our patients and say, okay, this is a really old, frail cat. I don't know that I want to start doing a long duration drug on this cat, right? I don't know if it's going to clear the buprenorphine. Can it metabolize the buprenorphine? I don't know. So I would start with something shorter duration that we can control a little bit better, right? And this has nothing to do, it's still an opioid response, right? So Zorbium, Simidol, they're buprenorphine. We know buprenorphine. But the duration might impact my patient that I chose it in. And then also explaining to owners that euphoria, that your cat may look different at home, and often their pupils are dilated, and that freaks owners out if they don't know why, that it's from the opioid. They think it's still the anesthesia. So explaining to owners that there might be a change in behavior for a few days in the cat. So I think with those two things, really thinking about which patient we put a long duration drug in until we really get good experience with it. They're both fairly new. And then preparing the owner for a bit of a different cat, and that might be a really happy cat. So thank you, guys. Always good to know effects and adverse effects, right? Okay, so we're going to stabilize our cat, but we need to get the periodontal disease fixed. And you can see here that we sent him home for stabilization. He comes back and we have a stable glucose level, no white blood cells or bacteria in the urine, and no glucose in the urine. So good, we're ready to go. Our concerns and our goals, of course, we don't want serum glucose fluctuations. Hypoglycemia can be really dangerous. So we want to try to decrease any loss of glycemic control and keep that glucose, that serum glucose, 120 to 150. Everybody has a slightly different range. Use your range. This just happens to be mine. We don't want hypoglycemia is the critical part. And then I try to get them back to food as quickly as possible, right? Get them eating and let the body control the glucose. Dehydration through osmotic diuresis means that a lot of times these patients need a higher rate of IV fluids than normal patients. We know they're prone to infections, so we use appropriate aseptic technique. And some of them might have diabetic neuropathy, especially if it's a cat, which means they need more analgesia, right? They may be more painful because of that underlying pain. And then finally, some are fat, and so we need to dose on lean body weight. Sometimes we have to help them breathe, and some are thin, and we've already talked about that in patients with renal disease. So here's day of anesthesia patient care. So now Harley is stabilized. Anxiolytics again. Harley's so anxious, no stress. I would use gabapentin and just a short fasting time, right? We don't want a long fasting time and hypoglycemia. And there's some good fasting guidelines in the 2020 anesthesia and monitoring guidelines from AHA. Those are absolutely free, open access. Google AHA guidelines, download the anesthesia guidelines. Yes, I am one of the first authors. I don't make money on these, they're free. And the other first author is my very good friend, Jen Sager, who is a veterinary technician specialist in both anesthesia and emergency and critical care. So again, someone doing the anesthesia. So please download those. Also, meropitant, don't want this patient vomiting, A. And B, remember that dogs that receive meropitant as part of a pre-med return to eating more quickly than dogs that don't receive meropitant, and we want this dog to eat. And then we're going to monitor the glucose. And just really quickly, because we mentioned a specific product, all of the other drugs that we've talked about so far are available as a branded product, but also generic. Cerenia or meropitant is not. So we need to always, when we're talking about a specific product, talk about efficacy and safety. And so just remember, you can download the safety statements from any drug from the company's website. So always know efficacy and safety. All right, let's just zip through this really quick. Yes, yeah.
Questions for you.
Excellent.
One question is, what's your preferred method of monitoring blood glucose during a procedure?
Very good. I'm going to come back to that. Somebody's reading my mind. So
Okay.
I'll be right back to that in a slide coming up. And then if I don't answer the question, please repeat how you exactly, if you wanted more detail, whoever asked the question.
And then also, how soon should you give Cerenia prior to surgery?
This Cerenia, at least an hour. We really want that Cerenia on board and working. So like in these patients, it's pretty easy because we're doing some stabilization in the practice anyway. So as soon as they come in, we give the Cerenia, and then we're checking the glucose and all the things we need to do. So at least 1 hour. Longer is fine. Okay, so with Harley, opioids for sure, benzos for sure, alfaxone, a good option. ACE promazine, again, in this patient is not optimal. Y'all are going to think I don't like ACE, and it's not true. But again, there's a specific reason in this patient. ACE is long duration, which is good if we want that. I don't want that in Harley. I want him awake and eating. And then the alpha-2 agonists like dexmedetomidine are a good option. And it's very discussionable, not really controversial, but you'll hear both sides. Some people say no because they cause hyperglycemia. I say yes because it's a transient hyperglycemia. And I'm more afraid of hypoglycemia than hyperglycemia. And because the alpha-2s are reversible, so if they have a slow recovery, we can fix that. But there are different opinions. And then for induction, again, the same considerations, propofol, ritomidate, great. I put green around them, again, just because we can titrate them to effect. But honestly, ketamine or taletamine, zolazepam would be great. Etomidate would be fine. Not inhalant, again, we've already talked about that one. So now how about maintenance? Wow, these are painful. We might need to add more analgesia. Look at how highly innervated this area is that we're working on, right? And there's already pain of inflammation, and now we're going to go in and anger some nerves. We need local blocks. And also, I recommend a ketamine infusion because central sensitization that occurs in the spinal cord, which is that amplification of the pain signal, is very common in patients that are already painful, and then we cause more pain. So central sensitization, very likely to occur in patients for dental procedures. And remember, we counteract that with ketamine. Okay, so now the monitoring, I use a handheld glucometer, and I check the glucose every hour. Unless it's changing, so it's going up or down, so I need to check it more often, or if I do something to change it, like if I start a dextro CRI, then it's every 30 minutes. So honestly, you can't do it too often. So every 30 minutes is great, but every hour is enough in most of them. And then if that dextrose starts dropping down to below 100, 120, so it's decreasing, I'm going to add some dextrose. Again, that's not too low of a glucose, but we don't want it lower than that under anesthesia. And then keep them warm so they wake up. All right, and then recovery, again, support and monitor. Recovery, support and monitoring, definitely treat pain. Check the glucose if the recovery is prolonged. And then I try to give them just a little bit of moist food as soon as they're awake enough to swallow. We don't want anybody to choke, but just a couple of tablespoons in a dog and a couple of teaspoons if it's a cat, just to get that body regulating its own glucose again, right? It's not exogenous. It's not us doing it. The body's doing it. So this is the protocol for Harley and the outcome. And so this is the end here pretty much. So we can squeeze in a few more questions. I know I talked a little bit longer than intended, but I had so much to share with you guys. You're my favorite audience. So you can see Harley, gabapentin, meropenem, hydromorphone, dexmedetomidine. Again, we looked at all of the drugs. They're all good. Midazolam, propofol, it could have been alfaxolone, isoflurane and blocks, and the ketamine, and then buprenorphine and carprofen postoperatively. We started the carprofen post-op instead of pre-op because remember we said that these diabetics undergo a lot of osmotic diuresis, and so they are prone to hypotension because of decreased circulating volume. So if hypotension is likely to occur intraoperatively, I wait until post-operatively, but NSAIDs are not contraindicated in this dog. So that's just it. Remember your diagnostics so that we can stabilize these patients and improve anesthetic safety. And then thanks to all of you guys and to Zoetis. And now, what other questions can we answer, Dr. Sura? And Lori. Hi, Lori and Dr. Sura.
Actually, somebody did, sorry, wanted to know where they could get the books that you spoke of.
The books that I spoke of. Oh, so I think, so there's some articles that I spoke of. So one of them is the IRIS stage of the kidney, IRIS Kidney Renal Society. So you can just Google that. It's open access. So IRIS, IRIS, and great information on how to handle cats with chronic kidney disease. And then the other one was the AHA pain anesthesia and monitoring guidelines. And again, Google AHA.org. You don't have to be an AHA practice to get these documents. It's total open access. And just look for the guidelines once you get to the AHA page and download them. There's tons of them. They do a really good job with their guidelines. What else can we answer?
So you had there's another question, which I feel like you might have answered, but perhaps they wanted something more specific. Do you still recommend a post-surgery snack if the patient doesn't get dextrose?
Yeah, absolutely. Regardless, yeah, good question. Regardless of whether they got dextrose or not, I like to get them eating again because that does help the body maintain glucose instead of us trying to control it. We want them back on normal feeding. That's to me really critical. So yes, still a snack. I always want a snack myself.
Do you have any general suggestions for dogs with liver disease or elevated liver values?
Sure. So again, I know, like I've said it like 6,000 times. So here's 6,001. Really support that oxygen delivery. That liver doesn't need any more insults. So we need to make sure that oxygen delivery is supported. So be very quick to jump on hypoventilation or hypotension and fix it. And then I stay away from drugs that require hepatic metabolism completely. So I like reversible drugs like dexmedetomidine, again, is a good choice, but ACE is not because it has to be metabolized by the liver. Propofol is a good choice and alfaxolone because they're cleared by multiple routes, not just by the liver. So just really focusing on keeping the liver as healthy as possible with oxygen delivery and not giving drugs that can't be cleared in any other way besides hepatic.
Somebody was asking if there was a way to get a copy of the slides. They wanted some more information on, where was it at? On ketamine, I guess? Yeah.
I think so. We'll have to check with Zoetis so Dr. Sura can help us check. And then if the answer is yes, then we can get those disseminated. Would that be through you, Lori?
If you can, I can get them out to everybody that attended. It is being recorded, so we will be putting the webinar up on our website. So,
okay, so everybody could watch it again as well. Okay, excellent. And I could provide you with a handout on ketamine too, and you could put it on the website.
Is there anything particular that you do differently with Addisonian or Cushingoid patients surrounding anesthesia?
For all of the endocrine diseases, to me, that they are some of the scarier ones for anesthesia. So absolutely as stable as possible for those patients. And then addressing whatever, excuse me, is happening at the time when they are presented, just as usual. So they may be hypotensive, they may have arrhythmias, and so addressing those. And then true with all patients, but I don't know, maybe especially endocrine, keeping the anesthesia as short as possible. So really being prepared to get in there, do what needs to be done, and get out. And then other than that, of course, maybe some specific drugs based on the endocrine disease, but not too many really. It's still sedation and then choose your induction drug that works rapidly, local blocks, kind of the same anesthetic protocol, but more management.
Okay, there's another question. I'm sorry, I'm trying to scroll through the chats where several of the questions are. Do you still recommend 1 hour or greater pre-med time for meropitant if given IV instead of sub-Q?
It is a bit faster IV. If we can have an hour, that's always nicer, because we want to prevent vomiting. So we know the more time for onset, the better. But no, it is faster giving it IV. Just remember, if you give it IV, give it slowly over a couple of minutes, right? Some patients will get hypotensive if you give it really rapidly IV. It doesn't happen very often, but it's easy to prevent. And then maybe back to the sub-Q as well. I know some people don't like the sting, and I hate pain. I don't like sting either, but I will trade that short sting for 24 hours of no vomiting, right? The trade-off is really, really good. But so back to your answer, yeah, a little bit less time for IV.
And it looks like there's one more question in the Q&A. Any insight for Addisonian or Cushing's pets or pre-med inductions?
Yeah, so back to the endocrine diseases, they're also different. That would be like a whole nother lecture, which I would love to do sometime. But those patients really need to be stabilized and monitored. I mean, we're good at monitoring and supporting anyway, but even closer, because with the endocrine diseases, they can change really very quickly under anesthesia. So I don't like to anesthetize any of them unless they're stable, and then decrease that stress response. So pain relief, pain relief, pain relief.
Well, I would like to.
Go ahead, Roy.
Go ahead.
I wanted to pitch it back to Dr. Sura about the onset of meropitant IV. You probably have a more professional answer than I did. Yeah, a little bit shorter. You would be more expert than I would.
Unfortunately, I actually have just been with Zoetis a month, and I'm on the diagnostic side, not the pet care side. So I actually don't support Serenia. So unfortunately, I don't have a better answer than you do.
Everybody's stuck with mine. Perfect. And Lori, I interrupted you. What were you going to say?
No, I was just going to thank you for all of your insight tonight, and just if anybody else had any more questions to put them in the Q&A, but just thanking you and Dr. Sura and Zoetis for sponsoring tonight's webinar.
Yeah, absolutely. I echo that. And again, you guys are my favorite audience. Thank you so much to NAPTA for bringing us together. I mean, what better way to spread the news of anesthesia and pain management than speaking to the people that are actually doing it? So much appreciate your time and all you do for our patients. It's a great organization.
Let's see, we might have, here's a question. Are there issues using propofol in cats?
No, and I'm so glad you asked that. It is such a myth. That is a total myth that propofol can't be used in cats. And so cats are missing out on this really good drug. And there was some concern, a myth concern, it's wrong, that the Propoflow 28, the propofol that can be open for 28 days because it has a preservative, that was toxic to cats. But there was a study out of the UK at 8 milligrams per kilogram 3 times in cats, and nothing bad happened. I'm more afraid of the propofol dose at that high than I am the preservative. Plus, in the EU and the UK, Propoflow 28 is the approved product for cats. It's just not approved in the US because it just wasn't studied in cats. So it's not on the label, but we all use it. And it is the approved drug outside the US. So definitely safe for cats. Thanks if you ever asked that. Let's clear up that myth.
Well, that seems to be all for the questions. And again, ladies, I really would like to thank you for your expertise. I hope everyone got a lot out of it tonight.
Me too.
Everyone have a great holiday season.
Yeah.
See everybody in 2023 with a lot of good new webinars from NAFTA. And if there's no other questions, everybody have a great evening.
Yeah, thanks again. And again, thanks to NAFTA and Zoetis and to you guys. And thanks you guys for putting up with my dogs that were supporting my points as we run along.
That's okay. Have a good evening, everyone.
You guys
Take
too.
care.
Thank you.
Bye-bye.
Bye.